Cabozantinib versus Everolimus in advanced renal cell carcinoma. My name is Daniel Ocampo. Definition. Renal cell carcinoma is the most common form of skin cancer with more than 330,000 cases diagnosed and more than 140,000 deaths attributed to it worldwide every year. Approximately one-third of patients present with metastatic disease at diagnosis, and about one-third of treated patients with localized disease, the disease will relapse.
The trial asked the question whether cabozantinib is superior to everolimus. Everolimus is an mTOR inhibitor considered standard treatment in second line or later therapies in RCC. Cabozantinib is a dual VEGF inhibitor, also MET inhibitor, and XL inhibitor, and these two important targets have been involved in resistance to VEGF inhibitors and to progression in preclinical models on VEGF inhibitors, as well as poor prognosis. So cabozantinib target multiple kinases, including the VEGF receptor, as well as MET and XL. So it's an unmet need. VEGF resistance is an unmet need. So the trial asked the question, is progression-free survival, the primary endpoint on the METEOR trial, superior with cabozantinib over everolimus? And now at the European Cancer Congress, we have the result presented yesterday showing that cabozantinib is associated with a 42% reduction in the risk of death or progression compared to everolimus. This corresponds to a highly statistically p-value less than 0.001. So the trial met its primary endpoint.
Applications in medicine. Cabozantinib is an oral small molecule tyrosine kinase inhibitor that target vascular endothelial growth factor receptor, as well as MET and AXL, each of which has been implicated in pathobiology of metastatic renal cell carcinoma or in development of resistance to antagonistic drugs text.
The treatment of renal cell carcinoma has changed considerably in the past several years. When we think back to the initiation of therapy, we had TKI therapy as the mainstay with sunitinib, pazopanib, and after that there were several other TKIs you could use afterwards. Really the sequencing was unclear and pro-inhibition TKI. Then we had the pivotal METEOR trial and CheckMate 2.5 done at the same time, showing that both cabozantinib and nivolumab offered us improvement in overall survival in the second-line setting. And so that led to a pattern of care where patients would start with a TKI, go on to receive cabozantinib, and then nivolumab, or vice versa. They would go on TKI, nivolumab, and then cabozantinib. And now, as we look at things evolving, the role of immunotherapy has really moved to the front line with nivolumab, ipilimumab approved in the United States, front line for those with intermediate poor risk disease. And we've just heard data on the combination of axitinib and Everolimus showing marked improvement in response rates, PFS, with a press release for pembrolizumab showing improvement in overall survival in the frontline setting compared to sunitinib. So clearly immunotherapy is moving into the front line. And so one of the dilemmas we face is with cabozantinib being studied in VEGF refractory, does prior immunotherapy really, does it affect the activity of cabozantinib? And so that's unlikely to be studied prospectively. We did a retrospective review between ourselves and Emory of 86 patients who had received immunotherapy as the most recent line of therapy and then went on to receive cabozantinib. And what we showed overall is that the activity of cabozantinib was preserved. So by investigator-assessed response, 36% of patients achieved a partial response. with 79% deriving clinical benefit, either stable disease or partial response, with a median time to treatment failure of over 6 months. So I think there's a lot of subgroup analysis that we've discussed in detail on our poster. I think the main takeaway is that in the setting of prior immunotherapy, cabozantinib continues to have an important role and will continue to have a role in the second-line therapy for our patients with metastatic renal cell carcinoma, and just gives us another definitive option for our patients in that situation.
Pros and cons. The incidence of adverse events, regardless of whether the event was considered by the investigator. To be released to study treatment was 100% with cabozantinib and more than 90% with Everolimus. And the incidence of adverse events of grade 3 or 4 was 68% with cabozantinib and 58% with Everolimus.
So the METEOR study was done to see whether a c-MET, an AXL inhibitor called cabozantinib, could be a standard of care in kidney cancer. So it was developed in second line after TKI failure, 1 or 2 TKI, and was compared to Everolimus as nivolumab was done previously. So the idea was to see whether this drug was able to improve progression-free survival in first primary endpoint. And it does. Cabozantinib almost double the PFS compared with Everolimus with 7.4 months PFS. This is very impressive. Response rate was also much better with cabozantinib than with Everolimus. The toxicity profile of cabozantinib is a little more complex because we need to have dose reduction with this drug. We need to do how to manage the drug, but it's in the same range of the TKI we usually use in kidney cancer. Based on the data from METEOR study, cabozantinib probably will enter the guidelines because that's active and very active in second or in third line in kidney cancer. One of the questions we'll have with two drugs actually very active in second line will be how we are going to use and to sequence the drugs in the future. That will be for the next studies.
Each application in Ecuador. Kidney cancer was the seventh most common malignancy of accounted for 3.3% of all newly diagnosed. Cancer is a 2012 renal cell carcinoma constitutes approximately 95% of all kidney neoplasms and 25-30% of all patients has metastatic disease upon its diagnosis.
I was lucky and fortunate to participate in the joint meeting of the EAU, the European Association of Urology, and the JAO, the Japanese Urologic Association. It was interesting. It was a mix of European-based uro-oncologists and Japanese uro-oncologists. And we had an interesting discussion what's the best second line in advanced metastatic renal cell carcinoma. And we have those standards in first line, but there's a discussion now with cabozantinib, levantinib, and nivolumab approved in second line treatment of metastatic renal cell carcinoma in some countries. And this talk focused on the value of nivolumab and had an interesting panel discussion. One oncologist had a lady from Barcelona, an easy task. She was pro nivolumab, which is right now guidelines recommendation second line RCC treatment. And one gentleman from Japan had the contrapart and voted for axitinib. However, and that's what he pointed out, no head-to-head comparison of nivolumab and axitinib. We just have head-to-head comparison of everolimus and nivolumab, resulting in a longer overall survival benefit for nivolumab as compared to the everolimus, and this led into approval of nivolumab a year ago, at least for the German market. So very interesting discussion here on second-line RCC treatment.
In conclusion, cabozantinib, multi-target MET, BGFR, and AXL tyrosine kinase inhibitor was associated with a longer progression-free survival as compared with Everolimus among patients with a renal-cell carcinoma that had progressed after prior BGFR inhibitor therapy.
In my mind, one of the key pieces of data that's being released at this meeting is the data for a drug called Cabozantinib. Cabozantinib is a dual VEGF receptor and MET inhibitor, and it's been assessed in the context of multiple diseases, including metastatic renal cell carcinoma. I've been involved since the phase 1 trials of cabozantinib and its development in renal cell, where we observed some very impressive responses. And it was more recently compared to Everolimus in a randomized phase 3 experience called the METEOR trial. This particular study identified an improvement in response rate, in progression-free survival, and overall survival in patients with advanced renal cell carcinoma. These three findings, in my mind, make it perhaps the optimal second-line choice in patients with metastatic renal cell carcinoma. That's based on data that was just presented today. They also revealed the fact that in a couple of months we might hear data from the Cabo-Sun study. This is a clinical trial which compared cabozantinib to sunitinib in the frontline setting, and that study being positive, although we don't have the full details of the data, may potentially supplant sunitinib with cabozantinib as frontline therapy.
Thank you.